All right, so hi everybody. We're actually going to be starting our psychiatry series where we're going to discuss the neuroscience of psychiatry. And we're actually going to start off with sleep and dreaming. These are going to be our learning objectives, which you can pause the video at any time and read more if you like. And we're going to start with some history. So, I guess to start off, I mean, obviously, since we've been invertebrates, we've been dreaming. And it's not surprising that we've had plenty of theories about why we dream that range from philosophy to religion. So, all of this, of course, was before we had any kind of notion of what neuroscience was. But in indigenous and shamanic traditions, dreams have been seen as a gateway to other realities. There's plenty of ancient civilizations like ancient Greece that saw dreams as sources of prophecy, healing, and moral guidance. Specifically, Aristotle saw dreams as a residual activity of the soul when sensory input was withdrawn. And after Freud's book on the interpretation of dreams in 1900s, dreams kind of entered the psychiatric consciousness and becoming one of the initial focal points of psychoanalysis. So the release of this book was a huge turning point for the field, as it showed that dreams were structured psychological phenomena rather than some sort of epiphenomena. Freud thought of this idea basically as some sort of wish fulfillment. Historically, it was kind of interesting that this actually came from the idea that, he made this new fun thing called psychoanalysis, and who would be his analyst. And so, after experiencing the grief of his father dying, he actually decided to become his own analyst by interpreting his own dreams, which is kind of, where this idea of dream interpretations kind of came from. And so, this eventually went on to become pretty structurally, complicated, using concepts like condensation and displacement, which kind of serve to protect sleep from these kind of, difficult and conscious drives that may be disruptive to the ego. And even though, a lot of Freud's work has grown out of favor, the idea that dreams are meaningful mental constructs has still lasted in the field, and it's still maybe compatible with modern neuroscience. Um, but going on later on in history, dreams really found their way into neuroscience with the advent of the invention of the EEG. This was really by, around 1953. There were these two guys, Eugene Aserinsky and Nathaniel Kleitman, which discovered REM sleep. And this was characterized really by three observations. So, rapid eye movements, autonomic variability, and cortical EEG desynchronization. And soon after this, some animal studies, which were by this guy, Michel Jovet, found that the pons specifically generated REM sleep and the atonia of muscles, that we can't move when we're dreaming. And this eventually all led to the localization of sleep. So going forward in time, by 1977, there were two psychiatrists from Harvard, Alan Hobson and Robert McCarley, which proposed that something that they called activation synthesis hypothesis. So this hypothesis pretty much argued that um, dreaming really happens in two phases. So the brainstem activates REM activity just randomly and automatically, and then the forebrain, the kind of frontal lobes and whatnot. Kind of see this aberrant, REM activity and try to make sense of it and fit it into a narrative. And so what emerges out of this is this experience that dreams are meaningful, but they're not really meaningful by design. So this theory was really important in challenging psychoanalysis, which of course, saw dreams as these very inherently meaningful things that required interpretation, while neuroscience is coming in from the back end and saying, like, look, like your brain is just trying to make sense of random electrical activity coming in from the brainstem. And so just kind of prioritize this sort of bottom-up view of neuroscience, contrasting this kind of top-down view coming from psychoanalysis. And so all of these kind of ideas sort of were challenged by Mark Solms in the late 1990s. And he did some lesion studies that showed that patients that had pontine lesions, which you would have thought have would affect their ability to have REM sleep, they could still dream. And so even people, this really, challenged this previous sort of activation synthesis hypothesis. But then what was interesting is that patients that had a damage to their ventromedial forebrain um, would actually lose the capacity to dream completely. And so this went on to demonstrate that dreaming doesn't really primarily depend on the brainstem, but instead relies on some dopaminergic mesocortical limbic circuits which are involved in motivation, affect, desire, and so on, which show that dreams are actually a form of uh, motivated mental activity. And so now, with all these lectures, I think having the cultural lens on top of these historical perspectives is really important in trying to kind of hone in on what it means to think of these subjects, at least from our own perspectives. So, in terms of cultural perspectives, of course, everyone dreams, and just about every pre-modern society has had their own ways of seeing dreams. And it's thought that maybe this gives us some special knowledge that might be inaccessible to us in waking life. So many indigenous traditions have kind of ritualized this practice around this idea. And this could be in the form of like vision quests or dream incubation, or whatever ritualized way that it may take form. They all help reinforce some communal meaning. Um, so, for example, in ancient Greece, there were these temples. I don't know how to pronounce them, but I think it's like Asclepian temples, that were these sacred spaces where people would actually go to sleep and sort of have healing dreams. And people who practice this, who were called the Messiases, I don't know how to pronounce that, believed that dreams were a communication of the body to the psyche, and that dreams themselves had narratives that needed interpretation, which of course is reminiscent of psychoanalysis. And aside from Freud, Carl Jung went on to greatly expand dream interpretation, specifically from a cultural context. And this was done by studying the shared experiences of dreams across different cultures. And some of the common themes that he found were that dreams, across cultures, may share some common archetypal imagery. And the sort of pool by which this archetypal imagery is drawn from is from what Carl Jung described the collective unconscious, which is kind of this shared cloud for symbolic data that's shared across cultures. And these dreams might actually represent a stabilizing force that might be an evolutionary thing that we all share to balance out our own conscious attitudes. Now, going to more the Eastern traditions, specifically in Tibetan Buddhism and Hindu philosophy, dreams can actually be seen as a training grounds for consciousness, instead of really needing interpretation, like all this Western stuff that we've discussed so far. So specifically in dream yoga, which emphasizes lucid dreaming, meaning that that you basically maintain conscious awareness while you dream. This was thought to be a way to understand the constructed nature of reality, the self, and perception. And now in the modern day, we've actually found some associations of this and other things in modern neuroscience, such as like some commonalities between REM dreaming and psychedelic states, like the reduced top-down control of psychedelic states and increased emotional salience and vivid imagery, symbolic narrative. Things like that are, some kind of overlap between REM sleep and dreams and psychedelic states. What with both of these states involving kind of the disintegration of the default mode network and enhanced limbic connectivity, and out of psychedelics and more of the computational neuroscience space, Some predictive processing frameworks have seen dreaming as sort of offline simulations, which is like where the brain goes to update internal models without interference from the outside world, which is sort of similar to the lucid dreaming frameworks and dreaming yoga, without the lucid dreaming, of course. And so all of this is to say that it's kind of interesting for us to see these parallels between modern neuroscience and what so many cultures have already known for hundreds to thousands of years. Um, we talked about like psychedelics in the West and sacraments to vision quests that kind of overlap with features of dreaming. While in the East, there's these like training grounds that can be better used to understand our own waking experience and ourselves. And in the modern day, we're only really beginning to understand some of the mechanisms behind this. But going a little further here in the East, you know, specifically in the Hindu philosophy, which is known as Advaita Vedanta, which is, of course, thousands of years old. There's a pretty interesting parallels between modern neuroscience and dreams. There's this text called the Mandukya Upanishad, one of the many Upanishads, which was written about, who knows, 2,000 years ago or so, which went on to describe each state of consciousness in pretty good detail, including sleep states. And of course, we've all seen this sign, which we see here on the right. But it's not as commonly emphasized that it actually symbolizes each of these different states of consciousness represented by each kind of like part of this sign. So which everything is written in here. So starting with the bottom part of the symbol, this part is kind of symbolic of the waking state called Jagrat. Uh, and this is also kind of symbolized by the top part of the EEG here, which shows a lot of muscle activity, which is showing the kind of like the waking state. And in Vedantic philosophy, the waking state is seen as consciousness turned outward, which leads to one identifying with their physical body and engaging through sensory experience. Then on the top of the three, looking symbol, we have what's called sushupti or dreamless sleep, which we see on the EEG as, various like non-REM parts of sleep, like stage 2 and stage 4, which we see here, and maybe slow wave sleep as well on EEG. This one's probably the most interesting. It's described as the state of no ego and non-duality, while somehow also continuing to maintain a sense of persistent awareness throughout. Which of course is not accessible to our conscious state. But when we wake up, we, can still say something like, I slept well, despite this kind of perceived lack of continuity in our conscious sense of self, um, which we'll talk about in just a little bit. But going outside of this, symbol that looks sort of like a number three on the squiggle here on the side, we see the dreaming state, which is called svapna. And on EEG, this would be kind of equivalent to REM sleep. And in Vedantic philosophy, this is seen as consciousness turned inward, with the mind generating its own world while continuing to maintain a persistent sense of self again. And so for the fourth state, which sometimes is actually just called the fourth state, this is represented by the uppermost dot here in the symbol, and it's called Turiya. And this kind of symbolizes an ever-present transcendental state. It's kind of complicated, but it's meant to actually explain why there's still a continuous sense of self even through dreamless sleep when we don't really have, conscious access to that sense of self. It's basically sort of like an enlightened state, and the little, line just under the dot. Is actually representative of Maya, which is the illusion of the waking state. And I guess like this illusion of this non-continuousness, when in reality there is a continuous self throughout all the stages of consciousness, which we see on the EEG. So yeah, like all of this, we can go in way more detail, but it's really interesting that these ideas that were probably thought of by some people that were just deep in the Himalayas thousands of years ago without any access to technology is still pretty, somewhat consistent with what we see in the modern EEG today, in terms of waking, non-REM sleep, and and REM stages of sleep as being distinct phases of consciousness. So I figured, it's worth including here. And if you're curious to read any more about this, I have some extra notes in the PowerPoint of this presentation here. So this is an important question, but why do we dream? There's not really a unifying theory that I found about this, but I figured we can go through just a couple different theories, just so we can have an idea of the variety of thought behind this. Of course, I'm sorry for the repeated mentions of Freud, but we'll start with him. And like we've already covered, the idea that Freud had of the purpose of dreaming is for wish fulfillment, which allows unconscious drives to be expressed while preserving sleep. And dream work in psychoanalysis actually includes, many different concepts and interpretation, like things like condensation, displacement, symbolization, secondary revision. All of these, we'll talk more in our future psychoanalysis lectures. But the idea is that basically things that we have repressed into our unconscious basically comes up while we're dreaming. And so, but then by the time that the person talks about that with their analyst, their defenses have already, have caused a secondary revision of this. And so it's the work of the analyst to try to kind of dig up these unconscious themes and what it means to the self. And so this kind of helps provide a narrative sense of these dreams and understand this raw, motivated affect that Mark Solms also talked about too. For the second bullet point here, for Hobson and McMarley, again, they created this hypothesis called the activation synthesis hypothesis that led REM sleep to be thought of as just random, signals that are coming from the pons that are then interpreted by the cortex, and it's largely random. And it's just the best shot at a coherent narrative that the cortex can make. Mark Solms, again, showed that, there's definitely some flaws in this theory. And REM sleep could still happen even with pontine lesions, but it can't happen through lesions through the ventromedial forebrain and the dopaminergic circuits also that are projecting to that area. And so, some thoughts that he had is that there's likely some dopaminergic motivational and affective systems that are motivating dreams, and dreams themselves are a motivated cognitive process. Um, One guy that we didn't talk about so much is this guy, Antti Revonsuo, who he kind of said that dreams evolved as a biological rehearsal system, which basically simulate threats and social challenges, and make sense of whatever, amygdala hyperactivation is going on during REM, to try to, motivate, a preparatory response to supposed threats. This also might explain, why there's recurrent nightmares and PTSD, for example, because there is a threat that basically needs to be simulated and thought of how we're going to deal with it in the future if it comes. And so this has a lot of parallels with modern computational frameworks that tend to think of dreams as offline simulation models to enhance predictive processing. And contemporary neuroscience, which is the last bullet here, emphasizes more so the importance of dreams and memory integration. And so all of these, are likely explaining probably the same thing, just at a different level, as dreaming is really known to be, physiologically enabled, of course, as we know with REM sleep. It's likely motivationally driven with these dopaminergic circuits. There's probably an emotional structure to it through this very active limbic system that we know stays active. and then it's narratively expressed through the default mode network. And of course, it could be psychologically meaningful, as we discussed through our subjective experiences, and of course, in analysis, it's the main focal point. So it's helpful to keep all these levels of understanding in mind as we go forward. So we're gonna get way more concrete now in talking about the functional neuroanatomy of dreams. We'll talk, yeah, let's just start with the hypothalamus. The hypothalamus is the primary regulator of sleep and waking states. It has neurons, that contain GABA and galanin. I wasn't actually familiar with galanin neurons before this lecture, but both GABA and galanin neurons populate the VLPO, which is the ventrolateral preoptic nucleus of the hypothalamus, and they function to inhibit wakefulness, um, promoting nuclei elsewhere. And there's also neurons that contain orexin, which are also known as hypocretin. This would be in the lateral hypothalamic nuclei. And the role of these neurons is to stabilize excitatory input to arousal systems. So basically, this interplay between the VLPO and the lateral hypothalamic nuclei sort of help regulate sleep and waking states. The thalamus itself is really interesting. It works as a rhythm generator and a sensory gatekeeper. So when we're awake, there's a tonic firing, which means it just maintains a stable tone of firing that helps kind of relay sensory input to the cortex while we're awake. But when we're asleep, it actually fires in bursts which generate these sleep spindles and delta oscillations that we see on EEG. But it's thought to also play the function of a sensory gatekeeper to kind of prevent sensory information from the outside world from waking us up during sleep. And so going down to more the level of the brainstem, there's this whole arousal system known as the RAS system. We're going to talk, this is going to be basically the main focal point that we're going to talk about in our next lecture, which is on disorders of consciousness. But we'll briefly review some parts of it here. So some components of the RAS system include different nuclei like the locus ceruleus, RAF nuclei, and these other obscure nuclei. The locus ceruleus, of course, secretes norepinephrine, so that mediates alertness and vigilance. The RAF nuclei secretes serotonin, so that mediates the stability of wakefulness and mood regulation. And these cholinergic nuclei, which are involved in cortical activation, are kind of originate from the pedunculopontine and lateral dorsal tegmental nuclei. And so, again, we'll discuss this on the next lecture, but it's important that these nuclei all project upwards to the thalamus and basal forebrain before diffusely projecting out to different cortical areas to maintain wakefulness. The basal forebrain itself projects cholinergic fibers that contribute to cortical desynchronization while we're awake and during REM sleep, which is why the cortex looks almost like it's awake when we're dreaming, even while also being completely disconnected from the outside world because of its connection, because of the gating function of the thalamus. Yeah, that's kind of, why we see so much thalamic stuff during different phases of sleep, while also, REM just looking very jarring as it almost looks like one is awake, and it's basically because cortically you kind of are, but you have all these other systems that are kind of keeping us asleep. And so the nodes of the default mode network also specifically when it comes to talking about the cortex are really important. Um, and I think this is actually one of the most interesting parts of all of this. So of course, as we know, the default mode network is kind of our narrative self. And most of the nodes of this network are active. So like the posterior nodes, which are like the posterior cingulate and precuneus, The hippocampus is like super turned on. And then I think the dorsal and rostral, medial prefrontal cortex are actually not as turned on. So like, what does all of that mean? Basically, you have you're able to tap into your memories from your hippocampus. You're able to kind of sort of have a narrative that's consistent and ongoing, but you don't have this sort of insight or this reflective self that would normally be coming from your medial prefrontal cortex. And so, even though your sense of self is ongoing, you don't have this metacognition and this reflective quality, which is why reality testing is obviously just non-existent while we're dreaming. And so you have yourself in your dreams, but you're probably not questioning all the weird stuff that's happening around you. Okay, so we're going to talk a little bit more from like a network perspective, or just kind of continue this trend of how these network dynamics interact while we're dreaming. So in functional imaging studies, we actually see some activated, so some regions that are more activated, such as the limbic areas and paralimbic areas. So this would include like the amygdala, hippocampus, anterior cingulate, and parahippocampal gyri, which we see there, as well as things that are a little more higher up, like the medial PFC, posterior cingulate, and precuneus. And there's also some nodes that are deactivated, which are really important, like the dorsolateral prefrontal cortex and the inferior parietal control regions. And this is not to be. It's a little weird because I don't want to contradict myself with the previous slide. The medial PFC, even though it could be somewhat activated, it's slightly desynchronized from everything else. Hence that lack of reflective function. While the dorsolateral PFC isn't really, active in trying to execute any tasks. This is actually more activated during like states of like lucid dreaming and things like that. So the executive network just isn't really working really well. So keeping this in mind, this kind of alludes to why dreams can be emotionally intense because you don't have these networks that are regulating this bottom up affect that's coming from lower brainstem, like limbic areas, which are still, working on high blast. And you can still have preserved autobiographical material because of the default mode network stuff that we talked about. But the logical consistency and reality testing is going to be lacking because we don't have this reflective function. But aside from that, the default mode network is kind of sort of, still fully on, like we said, and it's just less constrained by control from other networks like the salience and the central executive networks that aren't perfectly anti-correlated when we're dreaming, as it is when we're awake. And because the thalamus is kind of gating off sensory experience, it's also limited by, there's no active inference going on, which is a Carl-Friston term that basically means that while our predictive processing is on full blast. Usually there's some hypothesis testing that's going on when we're awake that basically screens out the things that are less likely to happen. And in dreams, it's just completely disinhibited. Like there's nothing that's really limiting you and your ability to kind of predict. And even things that are so out of like regular reality is not being fact checked either, because there isn't much of that reflective functioning happening in the DMN. While the limbic system is in full blast, which we kind of already talked about, but it's that last uh, full bullet point there. But it's also important that the dorsolateral PFC, which, like we said, is inhibited, usually plays a pretty active role in emotional regulation, which is another reason why the limbic system is probably more disinhibited and up too. And so there's going to be probably a poor ability to reason. And again, not to beat this with a broken horse, or I actually don't know the saying, but like that's why dreams are so odd, probably because of this lack of reality testing. And so, to talk a little more about sleep stages specifically, a typical night will include about 4 to 6 sleep cycles, each lasting about 90 minutes or so. This is there's more of a dominated deep sleep in the early cycles, and later on in the night, there's going to be progressively longer periods of REM sleep. The EEG gives us a kind of a peek at the coordination of these large-scale network dynamics that are occurring throughout the night. And so, just to go through some classic EEG findings that you can kind of see on the right as well. With stage one of non-REM sleep, that just begins right with sleep onset, right? When we start to go to sleep, and it's characterized by alpha to theta activity. So that's like 4 to 7 hertz-ish. And this just kind of represents the descent from wakefulness to sleep. And this is kind of the time when we might have some hypnic jerks or hypnagogic hallucinations, which is like when you're going to sleep, rather, contrasting that to hypnopompic hallucinations, which is what happened when you're waking up. By the time we get to stage two, this is like light sleep. We spend about half our total sleep time here. On the EEG, there's a lot of findings here. We can see sleep spindles, which we talked about, that could reflect things from the thalamus. And so this is like that thalamocortical synchronization. It's associated with memory consolidation, especially with declarative learning. Yeah, as we've discussed, this is like the thalamus basically blocking off sensory intrusion while we sleep. Um, and so by stage three, we see these delta waves, which are less than 4 hertz. So this kind of like high amplitude and synchronous firing of delta waves. This is more dominant in the initial third of the night. And it's associated with like the secretion of growth hormone, like immune modulation, lymphatic clearance, metabolic waste. There's a lot of like really interesting clinical stuff here. Like you said, like when we're like young, we say that like, sleeping is really important for us to grow. This is a thought. It's really important. Like when we're sleep deprived, we're more likely to get sick. And it's thought that there's an association between insomnia and neurodegenerative diseases down the line because that the lymphatic system isn't clearing out all the waste. And so finally, to get to REM sleep, this is also known as paradoxical sleep because, like we said, the EEG can sometimes look like somebody's basically awake despite being asleep. And physiologically, we see rapid eye movements, hence the name REM. There's also muscle atonia, meaning no motor movement, um, and some autonomic variability as well. And this is when we believe dreams are happening. And as we said, there's an emotional intensity during this time and reduced logical coherence in reality testing. Um, Let's talk about how we regulate REM sleep. It's kind of interesting that I am not making this up, but there are neurons that are called REM on neurons, and then there's also REM off neurons. So REM on neurons are primarily located in the pons, especially in the lateral dorsal tegmental area and pedunculopontine nuclei. So these are all like these kind of like cholinergic nuclei. They increase firing just before and during REM sleep. The REM off neurons, as you can imagine, are basically not on during REM sleep, but they begin to fire just after REM sleep and also on just about any time that we're not having dreams. So when we're awake and in non-REM stages. And the REM off neurons are located, basically anywhere that secretes norepinephrine and serotonin. So that's going to be the locus ceruleus and the dorsal raphe nuclei as well. So again, REM sleep starts when these REM off neurons are inhibited. And this allows the REM on neurons to kind of project their cholinergic stimulations to the cortex. And so REM sleep is going to end when these REM basically, I guess the REM on and the REM off neurons become inhibited, but eventually the REM off neurons are going to predominate. And an interesting aspect of these like REM on neurons is that they produce these things that are really important that are like weirdly named, but they're called pontogeniculo-occipital waves or PGO waves. And these waves are thought to originate in the pons and project to the lateral geniculate nucleus of the thalamus before projecting to the occipital and associative visual cortex. And of course, all of these areas are associated with vision. And they're thought to actually kind of scaffold this kind of, these visual hallucinations that we call dreams, and also contribute to rapid eye movements as well. Um, and so some, neuro-ophthalmology for REM there. And so while all this is happening when we're dreaming, the cholinergic REM on neurons activate inhibitory interneurons in the medullary reticular formation to release glycine and GABA onto spinal motor neurons to inhibit them from acting, so we don't actually physically, act out our dreams. Um, and whenever this kind of circuit is broken, that's when we see pathology like REM sleep behavior disorder, which is really aberrant cholinergic circuitry, um, which we'll talk about more later. All right. So here's just another view of how neurotransmitters help coordinate our sleep. We can probably cover this pretty fast. But first, when we're awake, there's really nothing to talk about here. It's just what you see there. Basically, everything's up aside from GABA. In non-REM states, that's when basically we see the opposite pattern of what's going on when we're awake, and GABA is now being released by the VLPO and thalamic interneurons. And so GABA basically suppresses arousal nuclei, and basically everything else is flipped. Everything else flips. Something that we didn't really talk about much, we just don't have time to, is the role of adenosine, which when inhibited is actually how coffee works and keeps us awake. But yeah, that's maybe if we could talk about that offline. And so for REM sleep, things are kind of like at a unique balance here. So while acetylcholine is basically up from these pontine cholinergic REM on neurons. Norepinephrine and serotonin are down from the inhibition of the REM off neurons, and GABA continues to stay up, and orexin also continues to be down from the non-REM sleep stages. And then I think that's basically it. But there's a lot more things that we didn't talk about here, like histamine is basically silent, since that histamine usually helps maintain alertness. So of course that's going to be down when we're asleep. And dopaminergic tone is actually relatively preserved throughout all this. Dopamine is actually a little interesting, since its activity is thought to be associated with ongoing salience and the vividness of dreams, which is why a lot of the medications that kind of change dopamine, whether it's up or down, tends to also affect dreams as well. Some people, especially with Parkinson's medications, can start complaining about like having vivid dreams all of a sudden. And lesions to dopaminergic forebrain circuits have actually been shown to abolish dreams, as we talked about with Mark Salm's work. Um, and dopamine agonists can increase dream intensity and dream recall. And so, dreaming, dopaminergic stuff is actually kind of complicated, but it's not just like a sensory hallucination, but it's actually thought to be like motivated mental activity that's driven by dopamine. And so, using all of these neurotransmitters, keeping all of them in mind, we can kind of have an idea of how certain medications work. Like when we use benzos or Z drugs, that's going to enhance GABA. It's going to promote non-REM sleep and suppress slow wave sleep depth. While serotonergic or norepinephrine meds like SSRIs, SNRIs, TCAs, they're going to suppress REM, they're going to lengthen REM latency. And anything that blocks dopamine actually is going to reduce this motivated aspect of sleep. It's going to reduce dream salience, and it's going to lead to sedation. And so we can also think about, at least briefly, we're going to talk about this in more detail a little later on, but how these neurotransmitters are also going to affect dreaming and sleep in the setting of different neuropsychiatric conditions, such as depression. There's an association of shortened REM sleep latency. And this is thought to be due to this like monoaminergic dysregulation and sensitivity to cholinergic stimulation. In PTSD, there's an excess of noradrenergic tone, which is thought to disrupt REM and intensify nightmares. In psychotic states, of course, there's going to be some dopaminergic dysregulation, and this is going to contribute to some dream-wake boundary disturbances. And I know we haven't talked much about orexin, but this is really important in stabilizing sleep. And when there's an orexin dysfunction, we see this in narcolepsy, where there's REM intrusion during wakefulness. And then, of course, an alcohol use disorder, alcohol enhances GABA, which is going to maybe make you a little sleepy in the day, but then it's going to fragment your REM sleep later on in the night. Okay, so now we finally made it to uh, things that are clinically relevant, starting with some kind of overlap with neuropsychology. And so, clinically, we have to think about the role of sleep and dreams as an essential requirement for emotional regulation, attention, executive function, and memory consolidation. And so, this is why sleep should be one of the first things we ask about in general when it comes to just about any of our neuro or psych patients, but especially when they're complaining about mood issues, memory difficulties, or executive dysfunction. So, from a neuropsychological standpoint, we see different types of memory becoming consolidated at different stages of sleep. In non-REM and especially slow wave sleep, we see this stage as supporting declarative memory, which is memory for facts and events, while REM sleep is more associated with emotional and procedural memory by recombining memory fragments into decent kind of novel narratives and preserving effective tone while loosening those contextual details. So patients with poor non-REM sleep may complain of brain fog and poor recall, while people who have disrupted REM sleep might be more emotionally dysregulated. And in terms of executive function, that second bullet point there, sleep deprivation and REM dominant sleep is associated with reductions in dorsolateral PFC activity. And so this results in deficits in top-down cognitive control. So in neurological terms, this can look hypofrontal. And so people can have worsened impulsivity, poor judgment, poor insight, and increased emotional reactivity, and have a lot of overlapping psychiatric features that might be similar to like ADHD, mania, and substance use disorders. And on that same note, this is also associated with impaired sustained attention, reaction time, and processing speed, and that may mimic mild neurocognitive disorder. It might also confound neuropsychological testing, so you should probably try to optimize the sleep of your patients before going into neuropsychological testing if they need it for any reason. And also, if you're managing any issues when it comes to emotion, it's important to really, beat it into your head that emotional dysregulation is really commonly exacerbated by insomnia. And there's this vicious cycle between mood and sleep. Like basically your mood affects your sleep, but then your sleep affects your mood, and it's terrible. So the way that this works mechanistically is that REM sleep typically reduces the reactivity of the amygdala in the next day. So if you have disrupted sleep, specifically REM sleep, there's going to be more, emotional ability, worsening of anxiety, irritability, and maybe even trauma-related symptoms, even the next day. So psychiatrically, this has some features that are shared with PTSD, mood disorders, and borderline personality traits. And interestingly, sleep disturbances are often preceded by cognitive decline. And so, like we kind of alluded to before, reduced slow wave sleep is associated with impaired lymphatic clearance. And so that might lead to some neurodegenerative disorders, or at least there's an association there. And REM sleep behavior disorder is commonly prodromal to all kinds of alpha synucleinopathies, diseases in the Parkinson's family. And so clinically, I personally often try to prioritize regulating sleep as early as possible in the treatment course of patients. And that's for the sake of trying to optimize everything that we talked about, like emotional regulation, attention, learning, and also their own ability to implement any skills that we go over in therapy. So I like that as like, an initial before talking about these specific sleep disorders. And so for the next two slides, I'm just going to talk about some primary neuropsychiatric disorders associated with sleep. First, we're going to talk about kind of things that are just have sleep sequelae, and then we'll talk about some primary sleep disorders. So first, in depression, depression is associated with shortened REM latency, increased REM density, and a reduced slow wave or N3 sleep, along with fragmented continuity of sleep. And so again, there's that vicious cycle going on. For another mood disorder, bipolar disorders actually, of course, while they're manic, it's associated with a decreased need for sleep, but still has the same shortened REM latency that you see with depression. And then after they're not manic, then in depressed episodes, it's going to be the same thing as depression. Um, in PTSD, this is associated with recurrent nightmares, fragmented REM, insomnia, and with hyperarousal and increased sympathetic activation during sleep. Again, the hyperarousal piece. And then people with schizophrenia and psychotic disorders, they tend to have fragmented non-REM sleep. Their circadian rhythm is just kind of disrupted overall. They have abnormal dream content, abnormal recall, and they have reduced sleep spindle density, which I'm actually not sure what that really means, but I'd imagine it leads to something thalamic. And Lewy body disorders, so this is like patients with like Parkinson's, and in that family, they tend to have early prodromal REM sleep behavior disorder, which can actually precede the Parkinson's disease by decades. And of course, this is defined by dream enactment behaviors with loss of REM atonia. Anxiety disorders tend to also present with reduced sleep, particularly in the N3 phase. They have prolonged sleep latency and they have increased awakenings throughout the night. And then substance use disorders, we'll talk about a little more in its own dedicated lecture, but it can also affect sleep in a lot of different ways. Like alcohol is initially sedating, but then later can fragment REM. Stimulants can delay the onset of sleep and reduce REM. Cannabis really alters REM and dream recall. And then when people stop smoking cannabis, they can actually have this rebound of just having a lot of REM sleep and really vivid dreams. So let's talk about primary sleep disorders. So, starting with insomnia, which is the most common of all, this is defined by a failure to initiate or maintain a sleep, maintain sleep. And it could be for all kinds of things. It could be primary or secondary to something else. It could be associated with a lot of psychiatric disorders. And it could be mechanistically, I guess it could allude to maybe some hyperarousal or impaired inhibition of wake networks. Hypersomnia or hypersomnolence disorders are characterized by the inability to sustain wakefulness, or kind of this collapse of the boundary between REM sleep and wakefulness. And actually, narcolepsy is included under this, along with sleep paralysis and hallucinations. Circadian rhythm sleep-wake disorders are defined as a misalignment between one's internal clock and the environment, while parasomnias are another collection of disorders that are defined by the intrusion of one sleep state into another. We also have some other things here that I think aren't talked about. Um, like these sleep related movement and breathing sort of disorders. The former would be like restless leg syndrome, and the latter is super common, but like obstructive sleep apnea, which could also be central. And then we also, just like anything else in the DSM, any kind of primary psych thing could be actually just secondary to substances or medication induced. And in future lectures from now on, we're going to be a little more loyal to the exact DSM-5 definition for all these things. But I figured this would be an easier way to just cover things a little more fast. Okay, so in terms of the workup, this is going to be a little long, so I'm sorry, and sorry for the busy slide. But of course, we always start with clinical history. Some of the questions that we have to keep in mind here is how long does it take for the patient to fall asleep? Are they waking up overnight? Is how is their sleep disrupted? Are they waking up in the early morning and unable to go back to sleep, or is it more, later on in the night? What wakes them up in the night, and what keeps them, from going to sleep. Are they having racing thoughts? Are they having restless legs? Are they having pain? And just to try to, eliminate all the confounders, to try to have a more cleaner treatment plan. And so, in terms of dreams, maybe, are there recurrent nightmares? Is there any reason for you to think that there's some PTSD? Are they acting out their dreams? What's their family history of Parkinson's, and related disorders? Are they having restful sleep? Are they waking up, gasping for air? And so we ask all these questions, of course, keeping in mind, any comorbid mood, anxiety, or psychotic disorders, maybe cognitive difficulties, sequelae from disrupted sleep, not only just common insomnia, but are they having those neuropsychological manifestations of poor sleep that we talked about as well, which are all, obviously really important in maintaining the patient's like quality of life. And then we're also, directing our questions a little more specifically to try to hone in on these comorbidities. Like, let's say, are they anxious? Are they hyper aroused for some reason? Are they depressed? How are they sleeping too much? Are they sleeping too little? And so all of these are all obviously important, like especially like, if they're just falling asleep in the middle of the day, or is it what kind of hypersomnolence kind of disorder is going on? Is it narcolepsy, and so on. And then we also want to see if there's any other medications that they're using that might be affecting their sleep. Like, are they a substance user are they like using a lot of alcohol that might be fragmenting their REM? Are they using a lot of cannabis that might be fragmenting their REM? Or maybe like rebounding with a lot of vivid dreams later? Are they using benzos, Z drugs, antipsychotics, antidepressants? All of these have their own effect on sleep. Um, so there's a lot of variables here. And so what I personally like to do, especially early on, is ask patients to try to keep a sleep diary for at least a week or two. So this can give us better data and kind of night to night variability to try to establish if there's any patterns from night to night. And I also like to ask for them to also report their subjective sleep quality, like how they feel when they wake up. And some more objective things that we have access to now is also like using sleep data from patients' wearables, like their Apple Watch if they have one. That could also be helpful. If you want to do something a little more medical, then we have, a sleep study, which is polysomnography, of course. This is actually a collection of studies. In a regular sleep test, we have EEG leads, EOG leads, EMG leads, EKG, and we're monitoring the respiration. So that's why we see all those wires in that picture there on the slide on the bottom right. And then, if we're suspecting something like narcolepsy um, or something like that, then after the sleep study, the polysomnography, we also can get a multiple sleep latency test, also known as the MSLT. And this is basically done the day after the sleep study, and it's after asking the patient basically to take a series of like 20-minute naps, like 4 or 5 20-minute naps or so. And we measure their sleep latency and their time to REM to kind of evaluate for like that REM intrusion, which is characteristic of narcolepsy. And the way that they make that diagnosis is that if the sleep latency is less than 8 minutes, and then that's more consistent with like an idiopathic hypersomnia. But if there's REM during those periods, then that's more consistent with narcolepsy. And so we can also use a bunch of different sleep scales that to quantify these symptoms and track response to treatment as well. There's all kinds of sleep scales. I personally haven't used them, so I can't talk much about them. But some common ones are the Epworth Sleepiness Scale for daytime sleepiness. There's also this quick 5 question survey called the Insomnia Severity Index. And then in terms of like to rate like global quality of sleep, there's the Pittsburgh Sleep Quality Index. And then for nightmares, there's the Nightmare Frequency Questionnaire. So ultimately, we can kind of gather all this data and, of course, like integrate them just like we do for any workup. But for sleep specifically, there's like 4 different schemas that I find helpful. Like overall, are the patients like suffering from excess arousal? Because if that's the case, then we think of PTSD or anxiety, or maybe even stimulant use. Second, are they suffering from like a state instability, like REM intrusion or something like that? Then we think of like narcolepsy, maybe even bipolar disorder. Is there like a circadian misalignment? Because then there could be like a shift work or delayed phase sleep disorder. Or is there just a disruption in their overall sleep architecture? Because for this, we think of like depression, maybe even neurodegenerative diseases. So for first line for a lot of sleep issues, it's going to be lifestyle. And the main lifestyle intervention that we do is just to encourage good sleep hygiene. And so, patients can look into this themselves, but it's always good for us to kind of give them an intro to it. So good sleep hygiene would include maintaining a consistent sleep schedule, creating a dark and quiet room that's ideally pretty cold. Avoid all blue light and screens for at least an hour before their planned bedtime. To avoid alcohol for obvious reasons, but also heavy meals at least 3 hours before bed or so. Try to implement a pretty stable routine about 30 to 60 minutes before bedtime. That's pretty relaxing. And try to reserve the bedroom only for sex and sleep. So you have those cues that you associate with sleep. And also try to, your best to aim to have this exact same time that you go to sleep and the exact same time that you wake up every night. If this doesn't work, then the first line psychotherapy would be a type of CBT, which is called CBTI, cognitive behavioral therapy for insomnia. This works. This is kind of called it's a long thing, but just to have a general idea of how CBTI works. The core components is stimulus control, which again is actually just good sleep hygiene, which is reassociating the bed with sleep rather than wakefulness. So no like watching TV or like using your phone in bed. Sleep restriction, which is to consolidate your sleep only for like a specific chunk of time. So you can consolidate your sleep drive and increase any like pressure from not sleeping from the previous night to kind of make up for the next night. And also like any CBT, there's a level of cognitive restructuring. Like, are there any kind of maladaptive beliefs that we need to target? Like, oh, if I don't sleep, I'll be ruined, or something like that, that is obviously anxiety provoking and doesn't help with sleep. And of course, like just continuing to reinforce sleep hygiene along the way, which I find really helpful to just not use sleep hygiene as just like a primary thing that we say, but also as a recurring reminder to patients as well, and also holding them accountable, asking them, to be like, well, how are you using sleep hygiene, or to teach back aspects of sleep hygiene as well. There's also like some behavioral aspects that could be incorporated into CBTI as well, like timing maybe light exposure to train circadian rhythm cycles, maybe taking melatonin about an hour or two before you're planning to go to sleep to reinforce these cycles, and maintaining those strict wake times that we talked about. And if patients are having nightmares, one thing that's probably underutilized, especially in PTSD, is what's called imagery rehearsal therapy, or IRT, which can be super helpful. Basically, it targets, nightmare disorders or PTSD, but it involves actually rehearsing the script for their recurrent nightmares while they're awake. And so the idea is that if you change the script of these recurrent nightmares when you're awake, you can actually hopefully change the script of when it inevitably happens again when you're asleep. Or even if it doesn't change, if you're expecting it, then it actually reduces emotional charge and that feeling of threat that, raises up your amygdala response. And then some other uh, the therapies, I guess, that are less commonly used but still helpful, is mindfulness-based stress reduction, and maybe some acceptance approaches, which would involve meditation, which could be really helpful as a ritual before bed, to kind of enhance calmness and reflection. It could also encourage kind of like a radical acceptance, which could be really helpful specifically with loving kindness or meta meditation. And of course, old school stuff like Freudian and Jungian dream interpretation. This could be helpful if patients have the resources for this kind of thing. Freud, of course, talked about dreams as being the royal roads of the unconscious. And so, but by the time that we hear about them, there's all these defenses. This is a complicated thing, but if the patients have the means to explore those things, it could be helpful. So this is quite a lot, but you can pause the video here to kind of review the general psychopharmacology of sleep. Like I said before, the first line treatment for sleep is lifestyle, behavioral, sleep hygiene, then CBTI if possible. And then, if not, you can start using these medications. Um, and so the first line treatment in terms of medications should really be targeted depending on the difficulty with sleep that the patient is having, and whether they're having, possibly like insomnia in the beginning of sleep, in the middle of sleep, or later on in sleep. And so, if the issue is, they just want to sleep like initially, like they're taking too long to sleep, then I think Ramelteon, starting from the top, could be helpful. This is a selective melatonin receptor agonist. The receptors are like MT1 and MT2. And again, this works in the suprachiasmatic nucleus and the hypothalamus, and regulates and helps regulate the circadian rhythm. It kicks in about like 30 minutes after taking it, especially if it's on an empty stomach, and it can be a helpful option for like sleep onset insomnia. And I think it's pretty cheap too, and it doesn't, cause any dependence. So that's pretty helpful. Some other meds are these dual orexin receptor antagonists, or DORAs, like suvorexant, lemborexant, and daridorexant. These kind of reduce the brain's wakefulness signal by blocking orexin. And it includes, these drugs that we talked about that kind of all are more helpful for sleep maintenance, especially if people are like waking up during sleep. But it does risk a little bit of the possibility of daytime sedation, but not so much dependence. So that's helpful. Then maybe, possibly third line could be a low dose of doxepin, which is a tricyclic. Um, it's a potent histamine receptor antagonist at low doses, like around 3 to 6 milligrams. And this is good for patients with middle to late insomnia. And I would just avoid this for older patients because there's a little bit of anticholinergic burden. Of course, it's found with just about any tricyclic. And they could have some anticholinergic side effects as well, like dry mouth, dizziness, constipation, things like that. The Z drugs are shouldn't really be used much, but you'll find a lot of patients that are on this, so I think it's helpful to know about them. The way that they work is that they're positive allosteric modulators of the GABA A receptor complex. So this is like similar to benzos. Initially, it was thought that there was a lower risk for abuse, but there's still some risk. Like I really, really don't like Ambien or Zolpidem. It tends to be really hard to get patients off especially older patients, despite this claim of like lower dependence. There's also like really weird side effects with Ambien that you can read about, even like with Ambien withdrawal too. So even if patients come in on Ambien, like let's say to the inpatient service, we probably shouldn't like, if they've been on it for a long time consistently, we shouldn't, try to use that time to stop their Ambien because they can likely go into withdrawal and have all kinds of weird neuropsychiatric symptoms. And so, benzos, I kind of feel the same. I mean, I included here just for completeness because we see it for similar annoying reasons. But those should only be saved for like dire circumstances, or in the inpatient setting. There's also sedating, like antidepressants. So if you're going to treat depression anyway, and that depression has insomnia, then it's kind of helpful that mirtazapine specifically is a pretty good antidepressant, especially if the patient has poor appetite. You can kind of hit three birds with one stone. You start at like, 7.5 or so, then go to 15 and kind of see response over time. Trazodone is super common. It's traditionally an antidepressant, but nobody ever uses it as such because it's so sedating. And so it's kind of an easy, old, cheap, relatively low risk agent. So we see it a lot. It's usually like prescribed at like doses of like 25 to 50 for sleep. The only times I use higher doses than that is that for patients with behavioral variant FTD, there's some case reports and some old data to show that it actually can help target sleep and behavioral issues with FTD. So that's kind of cool, I think. We generally try to avoid prescribing antipsychotics for sleep, especially to older people. But we do see it a lot. And if we're trying to treat anxiety, depression, or maybe even psychosis, Seroquel can actually be really helpful, and it's dose dependent. So low doses of Seroquel, like up to 50 tops, you can use for insomnia. And then you can go all the way up to like 150 or maybe even 200 for like depression, anxiety. And then, super high doses for psychosis, like 4 to 800, usually like the 6 to 800 range. But just the problem with Seroquel is that there's, of course, that risk of metabolic syndrome inherent in all the atypical antipsychotics, and it can also prolong the QTC as well. Antihistamines can be used for insomnia, but they really shouldn't. It's just not good to expose older people to that anticholinergic burden. And then for PTSD, what's really commonly prescribed is like prazosin, which is an alpha 1 receptor blocker. We're not 100% sure of how it works, but one of the low hanging fruits here is that it lowers adrenergic tone associated with like PTSD, hypervigilance. And so it can actually hopefully reduce the frequency of nightmares. We usually start at 1 milligram and then go up as tolerated and watch out for like, limiting side effects like orthostasis and so on. But this, ideally should be preceded by or with that imaging rehearsal therapy, the IRT therapy, which we talked about on the last slide. Okay, so that is our talk. And just to summarize the things that we talk about, sleep integrates a lot. It integrates the regulation of arousal, processing of affect, and consolidation of memories. Dreaming likely reflects the brain's attempt at processing and regulating our emotions and cognition. REM sleep is likely a personal window into our own internally generated simulations. And sleep pathology sort of provide us another window, which is into the imbalance of neurotransmitters and dysfunctions in the dynamics between neural networks. And more times than not, whether we're neurologists, psychiatrists, or even primary care providers, we should really prioritize helping to restore the sleep of our patients. So if you didn't learn anything at all from this lecture, I think that last bullet point is probably the most important key take-home message. And so these are my references. And thank you. And also in the PowerPoint, there's some review questions here if you're interested. Thanks very much.